All right, Dr. Muavha, I'm going to just introduce you. For everyone who's in the meeting, please note the meeting will be recorded for those who are unable to attend. So we are able to share the recording with them. So I'm going to introduce Dr. Muavha. I'll just read through his short biography, as you can see. And then he will immediately start with the presentation. We'll give him 20 minutes to 30 minutes, and then we will have questions that he will be able to answer, give advice on. Then we will close the meeting. All right, so Dr. Dakalo Muavha is an award-winning certified urogynecologist trained at the University of Cape Town. He is the head of clinical unit in obstetrics and gynecology in Petersburg Hospital and a senior lecturer at the University of Limpopo. He obtained his MB CHB at the University of Pretoria and furthered his studies to obtain a diploma in obstetrics and gynecology under the Colleges of Medicine in South Africa, CMSA. He also has a Master of Medicine in Obstetrics and Gynecology from UCT. He was then awarded a certificate in urogynecology from CMSA and a diploma in endoscopy under the Gynecological Endoscopic Surgical Education. Sorry for that, and assessment program. So Dr. Muavha is passionate about health education. I guess that is why he is here with us at the university at this point. And he is a PhD fellow at UCT. He has also helped in developing an educational app called Zavzide, aimed at supporting junior healthcare workers, especially those working in rural communities. He was recently awarded a Vatupili Award for Researcher of the Year. He's a chairperson of Limpopo Obstetrics Response Team, aimed at reducing maternal mortality in the province. He's an education committee member in the International Urogynecological Association and a board member of South African Urogynecology Association. So Dr. Muavha comes highly decorated, and we really appreciate having him today. So Dr. Muavha, if you can unmute yourself and set up your presentation for us, so you could go ahead. I've just canceled my presentation, so you could upload yours.
Windows, I'm here. Press below. So wait again.
Okay. It looks like Dr. Muavha is disconnected, so we'll just give him a minute or so to reconnect. All right, Dr. Muavha, you are back on. Just set up your presentation and the stage is yours.
I was struggling to hear from your side there.
All right, Dr. Muavha, we can hear you very well. Go ahead.
Oh, marvelous, marvelous. Thank you so much. With technology, you can prepare as much as you can. It always come and jump in there. So I think I was unable to hear you saying something from your side. So I'm going to just share the screen in a minute, and then we'll start presenting.
All right. So just go ahead and put it on PowerPoint. There we go.
Okay.
All right, wonderful. I'm going to mute myself now and allow you to continue.
All right. You can hear me loud and clear, and it's projecting from your side. All right. So I presume you can hear. So, ladies and gentlemen, thank you so much for joining me, and thank you for the invite from Rutendo and the team. I'm really honored to be invited to talk to you. Um, just to introduce myself, I'm Dr. Dakalo Muavha. I am a super specialist in urogynecology. Urogynecology is we deal with conditions of urinary incontinence and also fecal incontinence and pelvic organ prolapse in women. So I'm one of the first Black certified urogynecologists in the whole country. I'm currently working in Petersburg Hospital as a head of clinical unit in ops and gynecology. Um, I actually started my career, funny enough, Rutendo, in Univen. I think Rutendo were in the same class. I started in 2002 as a pre-med student straight from high school. I didn't pass so well for grade 12 mathematics, so I had to improve my mathematics. I went to Univen. So I will not divulge much, but I was one of the people who were squatting in F4 there from one, and I was sleeping on the floor the whole year and preparing to be where I am today. I'm saying this not not that I get sent a bill after this, but it's just to encourage young people who are there who wants to still achieve stuff and saying that is real possible. So I was asked to talk about some common problems or challenges which women encounter, which is cervical cancer. Just to talk about how do we do the screening for cervical cancer. So I will spend the next 15 to 30 minutes to talk about the screening for cervical cancer. And so the presentation will be just everything you need to know about this preventable disease of cervical cancer. I'll first talk about what is cervical cancer and cervical cancer screening and who is at risk and why is important to do cervical cancer screening and when to get screened for cervical cancer and what to do when you have the results of cervical cancer. Later on, I'll give you the take-home message. Tendo?
If I could just ask everyone else to mute their microphones and let the presenter continue. Go ahead, Dr. Muavha.
Okay, thank you, Rutendo. That's fine. So we can start with what is cervical cancer and what is the issues related to screening. So cervical cancer occurs in the cervix, which is the mouth of the womb. And this is when there is some cells which are would tend to be abnormal. So these normal cells of the mouth of the womb would become abnormal, and this usually happen over a long period of time. And the cervix connects actually the womb and the vagina. And the picture, if you can see on this side, you can see that's the uterus, which is the womb, and the vagina, and the cervix is the one in between there. So it connects the womb and the vagina. The causes of this cervical cancer, it's normally sexually transmitted and is caused by a virus called human papillomavirus. So in majority of patients who have cervical cancer, it's mostly the culprit. This virus is the one which normally would cause cervical cancer. And if you ask how would someone know whether they have a cervical cancer or not, the symptoms of cervical cancer, it's vaginal bleeding after sexual intercourse, um, or in between their periods, or someone who is not seeing their periods because of menopause, they may start having this irregular bleeding, or they may have this bloody vaginal discharge, or they have pain when they have sexual intercourse. But majority of people with cervical cancer is actually they have no symptoms. So when we talk about screening, we want to screen to be able to check the changes of cervical abnormalities before it turned to be cancer. As I said, cervical cancer happen in the mouth of the womb, but it's the abnormalities of those cells which happen over a long period of time. It can take around 10 to 20 years for these cells to turn from abnormal to being cancer. So when we're doing a cervical screening, we want to catch these abnormalities of the cells to change while they're changing before they get to cancer. So we normally use a screening tool called papsmear. I'm sure majority of you have heard about it. So papsmear has been in existence for about 70 years. So we use this papsmear. When you go to an obs and gynae specialist, normally would ask you to lie and lift the legs up, and they will put a speculum or something which allow us to be able to see the cervix. And we take a sample from the mouth of the womb, which is the cervix. And the other test we normally would use is to check for the virus itself. As I said, the causes of cervical cancer would be HPV or human papillomavirus. So to screen for cancer, we can also check if the person has this virus in their vagina, or and we do the HPV testing, or we can do both. Those are the things we use to screen for cancer. Cancer, who is at risk? If you are a woman, you are at risk. So cervical cancer is actually the third most commonest cancer in South Africa, and in Southern Africa. So it's very, very common. 1 in every 41 women will develop cervical cancer in their lifetime. So if you have, you are in a bus of 100 people, you know that at least 2 or 3 people in that bus in their lifetime, they're going to have cervical cancer. So if that is the risk, you can see it's very high. If you tell me that if I bet lotto every Saturday, I have a chance of 1 in 40 times to get lotto, I will bet every day. So think about it. In a bus of 100 people, at least 2 to 3 people having a possibility of having cancer. So it's very serious. And the people who normally at risk of having cervical cancer would be people who have early, who start having sexual intercourse early. When early meaning as a teen at 11, 12, 15, as a teen starting having sexual intercourse at that time, then you get exposed to this human papillomavirus. And if you get exposed early and it stays longer in you, and then it can develop into cancer. The other thing is early marriage, of course. For people who start engaging in early sexual intercourse, or who are married early and starting sexual intercourse, that predispose you from having cervical cancer. The other thing is nutrition. If you are in a position where you don't get enough nutrition because of poverty, your immune system become very low and you struggle.
Kana
It
online.
might be
Arife
difficult for you
zintu za both. Ya online inamsi what the physical.
all right. Sorry about that. I think there's someone was just saying something in there. So I was continuing with the people who are at risk. Poor socioeconomic status, people who live in deep rural areas where they are not having access to healthcare, who do not have access to do screening tests such as pap smear. So those are the higher risk of having cervical cancer. Immunocompromised patients, patients who are HIV positive, patients who are diabetic, patients who are having SLE, all this with the immune system being low, they're most likely to have cervical cancer. And the smokers, people who smoke, at high risk, they are at high risk of having cervical cancer. People with multiple sexual partners, you expose yourself to having a higher risk of having HPV, which is sexually transmitted. So if you have multiple partners, you are at risk. But these are not the only people. The fact that you're a woman alone, you are at risk. So everyone needs to be aware of that, including, even if we say that HPV is sexually transmitted, including those people who may not identify, who are women with a cervix but may not identify as women, are still at risk, because this HPV virus is not only, it can actually bypass even the protection measures such as a condom. So, and it can be also transmitted not only sexually, but it's mostly sexually, but just contact alone can result in HPV infection. So even if a person is not engaging in penetrative sexual intercourse, just contact alone can also result in HPV infection. As a result, they are also at risk. Why do we screen? Why am I here talking about this to you today? We screen because the abnormalities of these cells to become cancer, it takes a little bit longer. So we have enough time to be able to catch it early before it becomes cancer. So normally you find that a person has HPV infection, which changes the cells, become abnormal, and takes around 10 to 20 years up until it becomes cancer in majority of the people. I say majority because there are some people where this process can be accelerated, more especially those who are HIV positive and those who are immunocompromised. The period can be a little bit lesser. But the beauty is we can able to catch it early regardless. And that's why we screen, okay? And then if we catch it early, we have an opportunity to do something, like to treat it before it spreads. Cervical cancer is just one of the few cancers we have which is fully preventable, and it can be treated and you can get cured from cervical cancer, which means that if we are doing the screening, we are actually preventing a lot of deaths. And in Western countries, at this stage, for the past 30 years, they have actually halved the number of patients with cervical cancer. But it's not the same in Southern Africa, it's not the same in South Africa, it's not the same in Limpopo, it's not the same in our district, in Bembe district, because of the poor socioeconomic status, where not everyone have an opportunity to, or they don't present themselves to have the papsmear done because of many reasons, which include socioeconomic, low socioeconomic status. So it's important for us to do the screening, to pick it early so that we can able to treat it. And you would ask, who should be treated and when can you, who should have this screening done, and when can that be done? So when you start screening for pap smear, there is no exact time, but there are just guidelines. Well, especially for South Africans, the government has just put guidelines considering all the cost involved in doing pap smear for everyone. But the studies have shown that if we start doing pap smear after the age of 20, and between the age of 20 to 65, you can able to pick this before it becomes cancer. But in South Africa, because of financial reasons, the pap smear is recommended for you to start when you're at the age of 30. And once you have you reach the age of 30, you must do a regular pap smear screening. So a pap smear, you will do it every 3 years. If your first pap smear is normal, then you'll have to do it every 3 years. You can also do an HPV, as we discussed earlier on, which is a human papillomavirus testing. If it's negative, you can do it after every 5 years. But after the age of 65, you may stop to do a cervical cancer screening because we believe that if you are negative at that time, the likelihood for you to get HPV now or to get these abnormal cells up until it causes cancer at an advanced age like that is very unlikely. The other thing is that if you had hysterectomy where they remove the womb and the mouth of the womb, and if it was done for non-cancerous problems, for example, they've done it for fibroid uterus, then you don't have to do a pap smear. But if they remove the womb because you had precancerous cells, or you've got the cancers which are in the process of going to be cancer, or for cancer, or actually for precancerous cells, then you will have to do a pap smear. Or if you don't know if whether they have taken out the womb and the mouth of the womb at the same time, but that the doctor can easily see when you go to see your obs and gynae specialist. What to do with the results of cervical cancer screen? There are three possibilities when you have this test, and the doctor will be able to assist in that regard. But the results can either come and saying that it's normal after you do that screening test. If it's normal, then you can go and repeat the pap smear in 3 years. But if it comes back and say it's a low grade, we call it low grade cell or atypical squamous cell, then you may need, the doctor will discuss with you and decide whether you need to repeat the pap smear in 6 to 12 months. But in patients who are at high risk, who have a low immune system, who are HIV positive, you may be encouraged by your doctor to already go and do the further investigation, such as colposcopy, which is to put a camera and the camera will be able to go and look at these abnormal cells and see if they are suggestive of cancer. But if they are not, then you may repeat the pap smear in 6 months' time. But for those who would have what we call high risk from that result, high risk, high grade squamous cell intraepithelial lesion, you need to have a further test. Why do you need to know? Is because some of the people will go and have a test done by the general practitioner, and they say because the doctor didn't call me, then there's nothing wrong, which is incorrect. So when you do a pap smear, you need to also follow up and find out what is your results, and your results with the discussion with the doctor. You must decide whether you proceed to go and do a further test, or further test and also treatment, or you wait and repeat the pap smear, right? Because as you know, screening, we screen to pick those people who are at high risk of having cancer, and those who are at high risk of having cancer, then they have further test, which is a colposcopy, and then also if we find there's something wrong, then we can able to cut and remove those abnormal cells. So my take-home message for you, and thank you for listening, is with this cervical cancer, it's so easy to treat and it's easy to pick it up. There's no cancer which gives you a leeway of around 10 to 20 years. The other cancers, such as cancer of the ovaries, they are like a silent killer. You know, they only present late when they have already spread. But the cancer of the cervix, it's so preventable because it comes to you early, and if you pick it up early, we can able to remove these cells before they spread, and then you are cured, right? So it's important for you to be able to remember that. And then screening of cancer, screening of cervical cancer really save lives, because cancer of the mouth of the womb is the third most commonest cause of death in women with different cancer. If you put all the cancers together which women have, cervical cancer always come top in the cause of death in women, but especially in our area, in Southern Africa and in South Africa. So we need to get all involved. I see there are men here as well You're asking yourself, but I don't have a cervix. But I'm sure you know someone who's very close to you who is a woman. Okay. It's either your girlfriend, your wife, and if you're not fortunate to have any of those, I'm sure you were born from the womb by a mother as well. So you are also need to be involved in encouraging the people to go and have this pap smear done. And for us in a academic situation such as the university itself, and for us who are educated enough and able to get all this information, we need to share with those neighbors who don't get the opportunity to sit and listen to this kind of talks, and talk about and encourage everyone to go and have the test. I did it deliberately to be short so that I can get as many questions from the audience and we can able to discuss and have an interaction. Rutendo, thank you so much.
Thank you.
Yeah.
Thank you, Dr. Muavha. So a wonderful presentation. We've been having some technical glitches this side, but we're going to allow questions from the attendees so you could help them through.
Yes.
Yeah, if you have a question, you could raise your hand, unmute, and ask a question before we let Dr. Muavha go. Right, we have a question right here where we are sitting. Dr. Kabul. Yes.
Thank you, Dr. Dakalo, for the presentation. Last presentation, really brief one, but with rich information, and that will help us in the fight against the cervical cancer. What I want to find out from you, is you involved in, is there any way to one may himself control, I mean, the checkup of the starting point of the cancer?
Yes. Yeah, I didn't mention much of that. Yes, there is, and it's one of the good technology which has and is coming to be available in most of the countries. At the moment, it's mostly in Western countries. I know in Canada it's also being incorporated with their program for screening. So that self-test, doctor, the reason why it was done is because of the challenge we are all having in African countries, where women are unable to access these areas to do a pap smear. A lady from Hamashau, for her to be able to get to do a pap smear, she would have to take 3 or 4, two transports to go to a hospital, wait for a long queue, whereas she's not sick. She doesn't feel sick. And she wait for that long queue and ultimately have that pap smear done, and later on wait for around 6 weeks to get the results. And some of the people are not encouraged, it doesn't encourage people to do that because the process of getting that pap smear done, it's too long. And so the people who benefit are the people with medical aids, are the people who have to go to the hospital for other reasons. So in South Africa, when you look at how many people are having pap smear, you find that majority of people who have other medical conditions, they actually are able to have the pap smear done because they go to the hospital for other reasons. People who are HIV positive and taking treatment, it's because it's in the law that when you come to the hospital and HIV positive, you're above the age of 18, you get the pap smear. The doctor's going to be asking you to have the pap smear. But they have a group of people who are not sick, you know, a 35-year-old who is healthy, does not have any medical condition, does not have a medical aid to go and see a GP, does not feel anything or doesn't feel sick. Most of them don't come to the hospital. So they came up with this self-test, which is it's like a swab, you put it in the vagina, and it is able to pick it up like when you're having an HPV test, or it can able to pick up those cells of to see if it's precancerous cells. The challenge is, the reason why I didn't mention is because for you to be able to know whether is person has cancer or not, you must be able to take enough sample so that they can able to give the results. So if it's done by a person who is not taught how to do it, majority of the time you won't be able to get to the right spot and get the right sample, you know. So that's the little bit of a downfall. But with new technology now, they can able to pick all these cells even in the vagina. So it's something which is changing the paradigm of screening. It's something which in the future we're gonna have that happening in our country as well. So thank you for asking that. We hope that that will be of assistance for those who are unable to gain access to get those pap smear done. While we're waiting, it's important. That's why I spend the time talking about it. It's important for women to get tested. Rutendo and the doctor there, you'll be surprised how many nurses who come in advanced stage of cancer, who always they are there in the hospital on a daily basis, helping other people. But when they come to their own health, they neglect to come and have a pap smear done. They always postpone for another day, always postpone. You know, so while we're waiting for that technology where a woman can able to do that test or self-test at home, it's important for us. And it's good that this can be shared even in multiple media. It's important for people to be encouraged to go and have that test done, because that can prevent unnecessary deaths.
Yeah, Dr. Muavha, maybe Dr. Kabua will have a follow-up question. Maybe also answer, is it a myth that this test is very, very painful? That's why females are avoiding to do it. But Dr. Kabua has a follow-up question.
Yeah, doctor, thank you. Thank you for answer me on the first one. Secondly, I want maybe if you may help us. Everything is starting from, I heard from the talk, everything starting from the abnormal cells, then leading to the cancer itself. So can you help us and elaborate how one may, in terms of symptoms, feel that there is a no abnormal cell?
Yes, thank you, my doctor. So maybe quick one before I go to the follow-up with the doctor is that, is this test painful? The test is not painful at all, you know. And women, I see a woman saying, but doctor, you are a man. Even if I'm sounding like a lady, I'm a man. I wouldn't know if this is painful or not, you know. But with the experience of 15 years I've been working in the field, before I became a subspecialist in urogyne, I'm a trained obs and gyne specialist. With all that experience, the process of putting that speculum, it can cause discomfort, but it's not painful. And the benefit you get out of that is you getting an opportunity to prevent dying. You know, if you look at how many people are dying because of cervical cancer in South Africa, you go to I'm a head of clinical in Petersburg Hospital. You go to my ward, we have around 26 patients on a daily basis in the hospital, in that specific ward alone. But we have there in that ward at least around, we can go to around 7 to 13 people in the ward coming for advanced cancer treatment. Sometimes this advanced cancer treatment with Dendo, it's no longer curative because they arrive too late. It has already spread to the bladder, already spread to the liver, already spread to the chest. All we're giving is to give so that the last time of that person's life is not miserable because of pain. And if you understand that this is so easy, it could have been prevented. It gave us a leeway of 10 to 20 years to pick it up before it gets there. That's the sad part of it. So if you compare that, and having a speculum, which is a little bit of a discomfort, it's no brainer. You will need to have that test done. Yeah. And Lutendo, you'd be surprised how many health workers. I gave an example of nurses who are working in the hospital, including doctors themselves, including people who are doing this papsmear test. Some of them they neglect their health of not doing this test, and there's no excuse when you have 10 to 20 years leeway of picking it up, right? Thank you, Tender, for that question. So going back to the doctor here, yes, doc, the cervical cancer, initially it starts as an infection, and this infection is the human papillomavirus. So that infection is oncogenic, meaning that when it gets into the cell, it can change the cell, the way it responds, and it multiply and grow up until it becomes cancer. It doesn't happen to everyone who is having an infection though. And majority of the time, younger people, they have this infection and they don't know about it. And their body is able to clean it up. And when you check it later on, you find that they no longer have it because the body can able to clean it up. So in most of the people, a person will have that infection, but that infection will not be incorporated into the cell of that individual. And then they don't have cancer. It will just be the infection. But sometimes this infection can incorporate into the person's cell and then it changes the cell, how it looks, and become abnormal, which we pick it up by this microscope done through the pap smear. So we can pick it up while it's still abnormal before it becomes a cancerous cell. So sometimes even if it's abnormal like that, it's not yet cancer. The body itself can even work around these abnormal cells and clear them up. That's why when in my other slide said, when it's low still, there's still a chance that the body can clear it up. That's why we can wait for some 6 months and then repeat it again. But there are some people where it doesn't clear, it persists. More especially for people who have persistent infection, where you have multiple partners, you have this infection, you get it another one from another person, another one, and then it stays longer. When it stays longer, it persists up until it becomes cancer, right? Yeah.
Okay. So, Dr. Muavha, I think another question from our side here, sitting here, before we go to Ms. Mapepele Mashilo Lerato. We have a community that goes to see medical practitioners because there's something they can feel, or something very visible. Like you want to go and get a test or get a cure because you can feel pain in the cervix, for instance. Is there something like that that we should be looking out for before we even think of pap smear?
Good question. And I like that you mentioned that because it's important to emphasize that. Doc, by the time you see something or visible where you have a lesion or a mass growing, right? I don't want to say it's too late, but I'm saying it's a little bit more advanced, meaning that the cancer itself, I mean, the mass you can see with your naked eye, you don't need a microscope. Then we're no longer going to talk about screening it because you screen so that you see who is at risk of having cancer. When you now have that lesion or a mass which the doctor can actually see himself with his naked eye, then it's likely to be cancer. And what I caution my medical students, for those who don't know, University of Limpopo, where I'm now working, we've got a medical school, and which was, pushed and organized for the past six years, and now we have medical doctors graduating every year. And this was done with our help, with the help from our MEC, Dr. Popera Matuba. When I tell my student doc and say, if you find a patient who come to you already having a mess, you never do a pap smear. You must take a tissue of that mess and send it to the lab so that they can check if it's not cancer, because already it's a sign of cancer. Again, to answer your good question, is that how would you know that it's cancer? How would the patient now know that it's cancer? You will now see by having this foul smelling discharge. You will always have this purulent discharge coming out. When you have sexual intercourse, bleeding comes. You know, when your menstruation becomes irregular, your menstruation is no longer coming at the right time. It's just irregular. So all those things, and you start losing weight. We don't say what do you see before we start with the pap smear. Pap smear is the first thing. By the time you have all those signs, it's a sign that you already advanced. It's a sign that you already have a cancer. You might have a cancer. So pap smear doesn't work anymore. Let me give you an example which will go back to people and understand it better. When you go to different area and they screen and check your temperature to see if you might have COVID, right? And they check and say, oh, okay, the temperature is normal, then possibly this person does not have COVID. Let them come in. It's a screening test. But if a person come already shortness of breath, coughing, all signs of COVID, you don't say you're screening anymore. You want to now do a diagnosis to see if it's not COVID. You're no longer going to say, Mom, so the screening part has passed. You're no longer doing those screening tests. You need to now do a diagnostic test, which is to taking a patient and taking a tissue or doing a colposcopy to have those things confirmed. I don't know if you understand. The screening test is the first thing you do when you want to exclude from a lot of people who might have a cancer. But if a person already symptomatic, meaning that they present with problems such as a mass, as you say, such as bleeding, such as weight loss, we no longer screening. Now we know there's a problem. We do the diagnostic test, which is to take a tissue to the lab, or we do a colposcopy to put a camera in and check if there's cancer.
Yeah, no, we understand. It's you've said a mouthful. Great education. Miss Mashilo, followed by Miss Rikoto. Miss Mashilo, unmute yourself.
Okay, yes, thank you so much, Chair, and thank you so much, Doctor, for an insightful presentation. So mine is it's a question. My question goes as follows. I've been with the peer education program at the University of Venda for 5 years. So we
Ms. Mashilo, go ahead. We're listening. We seem to have lost him. Okay, yeah, go ahead, Ms. Mashilo, you're back.
Sorry, the network is poor this side. So yes, we used to have the dialogue sessions regularly. So wherein we'll be asking about so many health-related questions. So what we've realized is that a lot of females, they would complain that pap smear, it's very painful when you're doing pap smear. So that was making a lot of student females not to go or not to want to do it. So, but we had some few that would say, of course, they've done it and it's not that painful. So I'm thinking maybe it could be with, the issue could be with who is doing it. So do you perhaps have some evaluations, after maybe someone have gone through that process of pap smear? Do you then give them evaluations, maybe just to check on how was the experience and all that, so that you can now, track and say if maybe someone did say it was painful, and then maybe you do some follow-ups, or maybe you can maybe talk to the health practitioner to say maybe are they doing it, maybe I don't know, maybe in a I don't want to say wrong way or what, but yeah, do you do some kind of evaluations? Because that brought so many challenges that we ended up not having a lot of students or recruiting a lot of students to come and do papsmear. We do it yearly.
Yeah, Mrs. Mashale, and thank you, and really appreciate the work you're doing, because it's so important. You are mostly with the people who need the help, more than even the people in the hospital, and it's so important. And your question is bearing evidence to that, because you have an experience from the ground. Thank you for that. So pap smear should be done. The question from the previous question from the doctor, the difference between a pap smear and this self-test, which is being generated and is being researched on, is that first one, the patient themselves, they put it in, and just like a tampon, they wipe and then send it and get the results. That would be ideal, because that doesn't require a lot of education for a person to do it. But with a pap smear, people need to be educated to be able to do it. One, not only for the comfort of the patient, but so that they can able to know where to do a sample, so that it can yield better results. Because the worst thing you can do, membership, is to tell a patient that you don't have signs that you might have cancer, whereas you have actually sampled the wrong place, or you have sampled, you don't have enough experience to be able to sample the right, where the problem is. Give you an example with an investigating officer in a police, people who are coming to do checking fingerprint in a crime scene. If that person is not trained to know where to do those sampling, they will always not catch the criminal, and the criminal will continue and cause havoc in the community. The same thing with pap smear. If the person who is doing a pap smear is not trained enough, that person is actually a little bit dangerous, because they will be taking areas where we don't get the results. And the other challenges that now, even the process of doing it might be traumatic for the patient, because the person is not trained. But after saying that, I must guarantee and tell you, I'm also in the training of medical students. I can tell you there's very few doctors who will qualify as doctors and are unable to do the pap smear, because that is a basic thing which we teach from the second year up until final year in 6th year. So there shouldn't be someone who is unable to do a pap smear. But of course, with any procedure which you do to a patient, you need to have a technique of making sure that the patient is at ease. If you're going to put something into the vagina and the patient is tense and is scared and they are stiff, and you're going to put something which is plastic or steel, the procedure may not be painful itself, but the patient who is stiff and scared and worried, it can cause some, it can be very painful, So again, if someone, Mama Shelley, give you a varum clap once and you feel that pain, right? And you register in your head that this is painful. The next time when I show you a sign that I want to give you a varum clap, your body is already registering pain in their body, right? In their brain. And then you're going to feel that this process is going to be painful. Or you may even perceive the same sense when you're having pain, it may come. So the fear, Shelley, that is painful, it contributes to people's worry to come in and do the test. And it also contributes to the negative feeling of patients who come to have the test done. So people like you are crucial to be able to bridge that gap, to tell the patients that actually this test shouldn't be painful. In good hands, you shouldn't be feeling any pain. And I take your advice. I've never thought of it, of doing the post-test interview or a small questionnaire to say, how was your experience? Why did you think this was painful? And then we can improve on how we teach medical doctors in the future to say that you do it this way because patients perceive more pain when you do it this way. But
Thank you,
pain
Dr.
itself, it
Muavha.
shouldn't stop people from getting the test. Remember, Shelley, the last one, there are many people who go and have an injection done for prevention to not have a baby. And it is an injection and that is painful. But still people go because they understand that if they don't go, they're going to have unprotected sexual intercourse, they're going to have a baby whom they need to support. And there's a bigger consequences of that. They will go and have that injection done. I'm not saying people must feel pain when they have this, but I'm just saying the bigger picture of a patient dying from a preventable disease, it cannot be equated to the fear people are having.
Yeah, Dr. Muavha, thank you. We have run out of time, but we're going to give a chance for those who are remaining online to ask questions and let you clear them. So for those who are late going elsewhere, we appreciate your attendance. There's a second hand, Ms. Rukotso. Hopefully she's still around to ask a question.
Thank you so much, Chairperson, and thank you so much, Dr. Dakalo, for the very wonderful presentation. Your presentation was very informative. I tend to learn a lot of things. So I think I have two questions for you, Doc. So the first question is that we know that it has already been established that with papsmear, it is used to determine the morphology of the cells, right? However, there are studies now that are showing that patients who have tested negative, or who have a negative cytology test, right? They're able to detect some of the high-risk HPV types. So I want to know from you, Doctor, what could be some of the possible reasons for us to see such a thing, especially from someone with a negative papsmear test. So that's my first question.
Oh, okay, let me answer that quickly. It's a brilliant question, Ricotta. The pap smear itself, it's limited because of the a person who takes that pap smear. You know, a person who's taking, think about a person who's taking fingerprint. If they go and swab an area where there were no fingerprints, it doesn't mean that there's no criminal. It just means that the area where the swab was done, there was no fingerprints. The same thing with a pap smear. It needs a very experienced person to go and swab the right place, which is the transformational zone. And in older patients, the transformational zone may be a little bit inverted and inside. And if you don't get to the right place, no matter how good the interpreter, the person who look at the pap smear, the histopathologist, they won't find those abnormal cells. And it doesn't mean that they are not there. It just means that the person who swabbed it didn't get to the right place. The other thing is the interpretation of the person who is interpreting the pap smear, the histopathologist. In a high volume center, one histopathology look at the pap smear slide in less than a minute, and they decide whether they're abnormal cells or no abnormal cells. So we are relying on two people here to pick up the abnormal cells. One who does the swapping, and the other one who interprets that swapping. The reason why with the HPV it's better is because the HPV we cut in the middleman of interpreting. This can be automated, right? You get the swab from the vagina, or from the cervix or the vagina, you go and do the test, and it's automated and give you the results. There, they are not looking at the abnormality of the cells. They are looking at the infection, the HPV itself, and the one which is having an oncogenic property, right? So that one, at least that's why they can pick it more. The other thing is with the pap smear, if a patient comes to you already douched, some patients, they said they don't, because of the vaginal smell, they want to have a vaginal douche, right? And by the time you do the test, you find that you may not be able to pick up those cells, whereas it's actually there. So there are a lot of issues which affect the pap smear result, which come back negative, whereas there is a problem already, but it's coming back negative. That's why now we're using the water-based pap smear, which picks it better than the one we use with the slide, where we put the fixator and put it in the slide. The water-based get more of the results, which are better. Yeah. Because I'm not sure if I answered your question, the first question.
Answered, Doc. Thank you so much. So the second question that I have for you is, in a case where do pap smear and also has to go for HPV screening or detect. Right? I know that we do have a number of commercial kits there on the market. So I want to know from your side, like, which kit are you using, like, for genotyping purposes, and then why specific that that kit? Because I know that we have a number of
I think you got cut there, Rikoto. Just repeat the last part.
So I want to know from you, Doc, that I know that we do have a number of commercial kits there on the market, right? So from your side, which kit are you currently using, and why specific that one? Because I know that with different kits, they test for different, like, HPV types. I hope you are able to get my question now.
No, I get what you're saying. In our practice, in most practices, you can do both the pap smear and the HPV testing. Why do we do that? We want to expand the time where if you get a negative HPV testing and you get a negative pap smear, you don't have to repeat the pap smear in 3 years. You can repeat it in 5 years. So it makes patients not to come so many times, and all the fear of pain and everything at least is extended for not doing very often. So I understand that you have an interest with the issues of the laboratory. What do they use? I must confess, with us as the end user, normally we would take a pap smear with a slide, or we take with a brush, and we put it in the container, send it to the lab. The histopathologists are the ones who will be able to do, and we will ask for HPV a test, and they will give us the HPV based on the high risk HPV, the one which mostly known to be causing cancer, or it comes back and say is the low risk, or it comes back and say there's no HPV infection. But which one particularly the laboratories use, I'm not sure of what they use. But you can tell us your thoughts. What do you know about the different agents they use?
Thank you, Dr. Muavha. Yeah, Ms. Rikoto is a PhD student working with HPV. So you will get what comes from here. It's shortly. Yes, of course.
Yes, I love it. Also, we have students who are working in the lab.
Yeah.
Yeah.
Oh, okay. Yeah, no. So they actually asked me the question, I wouldn't know, because the last time I was in the lab, I was in Univen doing BSc playing as a pre-med before I got into medicine. So
Yeah.
so I wouldn't know.
I understand, classmate. Okay, let's move on. I see Ms. Mashabanduna has a hand up. If you could unmute yourself, or Mashabanduna, ask your question.
Thank you very much, Chair. And also thank you, Doc, for the wonderful presentation. As a layperson on the field, I just want to find out, when children are born, we are told that they must get immunization for certain diseases, so that even if they can caught them, it will be minimal. I just want to find out, with this cervical cancer, is there anything that is being done up to now for immunization, so that even it can caught a person at a later stage, it must not have that effects. Thank you.
Woma Shabanduna, I'm so glad you brought that, and I'm happy I did this shortly, so that we can have enough time to have this kind of interaction. And I think it's more helpful than getting a lecture on everything about cervical cancer screening and cancer itself. So it's very better to get these kind of questions. And I'm glad that this question was asked before we even finish about this. Yes, yes. Even our Department of Health in South Africa is encouraging vaccination for the young girl child. You know, from the age of 9 to the age of 14, between the age of 9 and age of 14, we encourage girl child to get vaccinated, because this can be prevented. We know majority of this cancer is caused by HPV infection. So HPV infection, you can get vaccinated, so that the girl child, when she's old enough and engage in sexual intercourse, she has already immunity to be able to clear this HPV, human papilloma virus, easily. We spoke about that majority of the people have this HPV. And I must emphasize, this HPV is able to also jump through a condom. You know, you do a protected sexual intercourse, you can still get the infection with HPV. You have a person who is orientated and not having a penetrative sexual intercourse with a man and being a woman, but still will have the risk of having cancer, because it's not only sexually transmitted, it can also go through contact. So to prevent it, it's this vaccination. And I know vaccination, there's fear mongering. There are people who say that when children are vaccinated, our child, they engage in promiscuity, they go and have sexual intercourse. That is not the case. We need to encourage everyone to go and have their children having a vaccination. So yes, the vaccination is there, and it's available in the public hospitals. It's also available in private. If you have a child and you have a medical aid and you can afford, you can able to give. In South Africa, we give only girls. But for me, and that is because of the financial reasons, nothing else, just financial reasons. But even boys should be vaccinated, because boys actually are the ones who are at a higher risk of transmitting to multiple people. You know, if you vaccinate one, I mean, this is for me, don't quote me, but if you vaccinate one boy, you're most likely going to prevent cervical cancer for 4 or 5 women. You know, that's my thinking. So if you are able to having a medical aid and you can able to afford that vaccination, you must give that boy the vaccination. You must give that young girl the vaccination. Vaccination is not also given not only for this group, patients who are HIV positive, patients who have never engaged in sexual intercourse earlier on, maybe the age of 20, you can still give that vaccination to prevent this HPV. And I really thank you for asking that question.
Dr. Muavha, thank you very much. We don't like stopping you while you're answering questions because it's very informative. So it looks like we're going to have to bring you here so we can talk to you face to face and ask you these questions the whole day. Bongobeni, your question, if you can unmute.
Thank you, Doc, for the information. It's really informative. I really appreciate it. But mine, I don't know if it's related to cancer, because there is this monthly pain, especially when there is a cold weather, like yesterday around here. It's below the abdominal. I don't know if I'm right, because usually when I ask the gyno, he will say, how do you know? Because you don't even know who is the position of the things. So that pain, usually in Chivenda, they call it kuli. I don't know if you know that thing. Sometimes you find you can't stretch your leg. It's very painful when you go to the loo. So I don't know if it's this other symptoms of some other cancer or something. I don't know, but I really want to find out, because it usually happen in cold weather, and on monthly basis, I know when it will happen. Thank you.
Okay. Bongovin, thank you for the question. Maybe while you're at it, you don't have to divulge much, but I need to understand a little bit so that I can answer you correctly. So you're saying is the pain just below the belly button, right? And it comes every month. You can even predict when the pain is coming.
Yes.
And does it happen during the time when you're menstruating?
No, usually they happen after a week after menstruation, and especially when there is a cold weather.
Especially when there's a cold weather. All right, good. Thank you. That's a good question. Majority of the time, just to allay your fears, majority of the time, cancers are not painful, right? Majority of the time. And the one way it's now painful is it's when it's already advanced, and it's painful when you are having or engaging into sexual intercourse, because in that. But if it just happens when there's weather, and it's happening regularly at a particular time of the month, it doesn't sound like it's cancer. So at least you should be happy with that, right? But it might be what we call endometriosis. Endometriosis is when there is a growth of the cells which normally found inside the womb and growing outside the womb. And that is the cells which responds to hormones. That's why the pain will occur at a particular time during your menstruation, because when you are menstruating from the womb and from the bleeding from the inside the womb, those cells as well, they menstruate inside the abdomen, right? And then you have this excruciating pain. And then normally this is not cancerous, but it's debilitating. Some people actually decide not even going to work or going to school. And if you are a lady already, you having this pain affecting your work, affecting your school, and there are times where you will be pregnant. So it affects your growth even socially. It affects your growth even academically, even promotions. So it's as serious to some people as cancer, because you're not living to your potential because of this problem. So we normally call this wongovin is chronic pelvic pain. If it happens regularly for more than 6 months in a period, we call it chronic pelvic pain. So it's not cancer, but it's still as serious as cancer, because it can affect your life. So some people, it affects their life. How do we confirm it? We normally nowadays we put a camera into the abdomen, we call it laparoscopy, and check with a camera and see where this problem is coming from. and then we can able to remove those cells laparoscopically. So it is not cancer, but it's something serious, and we can able to fix it.
Okay, thank you, Doc.
All right, thank you very much, Ngobeni. Thank you, Dr. Muavha. We seem to not have any more questions or comments. Let me go ahead and thank you, Dr. Muavha, for coming through. We are going to, I can commit that I'm going to speak to Director Communications, and they will communicate with you for the next session so that we have you here in person, because this was very, very, very informative, and I believe a lot of people will benefit from it. So here with me, I have Dr. Kapuengandu, who is going to give vote of thanks to you and to everyone else in attendance.
Dr. Dakalo, thank you very much. Before even go ahead on that, Dr. Yes, I forgot to ask for, we wanted from what we got in your talk as a gynecologist, why not really to advocate the government, for example, a policy or for a systematic checking. You see, I had, for example, the burden of disease is high, as you presented. Why you could not suggest, for example, a systematic control of the compulsory control of the cancer, the cervical cancer?
No, it's a good question, very thought provoking. One is doing a full screen cervical cancer is very expensive. In America and Western countries, the take-up rate of screening is around 70% of the population, of the women population. They get to be screened. And it's not compulsory, but they get to be screened. Why? Because the services where the screening is there, it's not, the health system is not burdened. Someone can go into a health sector and walk in 5 minutes, papsmear done, in 4 or 5 days, they get the results. In our situation, with all this communication, we are blessed here in Limpopo to have MEC Popera Matuba, who always, decide and say, we are the poor province, a rural province. We are of the same number of population as Cape Town, but our funding is lesser than Cape Town, which means that we can't win the war through getting all the equipments and getting all the hospitals. We win the war by encouraging women or encouraging people to understand their health and come early when there's a problem. The challenge with cervical cancer is this screening, is that we don't have enough already with the few number of people who come for papsmear check. The system, the health system is not geared enough to be able to take all this. If we say we're going to force everyone, like in my clinic, for example, on Wednesday, if I say I'm going to force everyone to come and have the papsmear done, it means that instead of seeing 50 patients in a day, I'm going to see 150 patients in a day, because people will be forced to get the certificate that they have been vaccinated. And as a result, the whole hospital will work only on vaccination, and the rest of the medical problem will suffer because we don't have that capacity. So it could work, but we don't have the capacity to take everyone else. And now you'll be taking everyone else, even those who are at low risk, even those who may ideally would not need to be doing that personally at that time, but they'll be doing it for compliance. And as a result, it breaks the system. The other thing from medical point of view is ethical issues. as medical healthcare workers, you can't force any individual, even if no matter how difficult it is as a condition. A point which we just finished, not finished, but we're still in with it, is COVID-19. We couldn't even get compulsory testing right because there were lobbies of people who said this is not acceptable. So imagine now you were doing the test through putting a swab in the nose. Imagine now I have to do, doctor, the compulsory test where I need to ask a woman to open their legs and do the test. You can imagine how many lobby groups will be coming at us and coming at the MEC and coming at the minister and coming at the president. You know, so I think it's a good idea, but it comes with a lot of unintended consequences.
Yes, it's costly. Yeah, we want to end up. We would like to be with you for more times. Doctor, thank you very much. Thank you very much for making yourself available and sharing with your practice as a specialist. It's not every day we may have a chance to hear a specialist in the field of nasal cancer. Thank you very much. We wanted to hear you more, and we hope this is the first time, maybe having more of the session with you. Why not here in the Venda University? Yes, we want also to thank everyone who attended, who wanted to listen to Dr. Dakalo. We engage in this way to give us some awareness to the cervical cancer. We hope we may this way going ahead in the fight against the cervical cancer. Thank you. Remember, this is as well the month, the women month. Yes, the Women Month. Yes, is the yes. Finished yesterday. We just coming from there. So we unfortunately last week we couldn't make it. So that's also in that order we want to organize and to be with you for this. Thank you very much.
Thank you so much. I really also want to thank you because you know for me as a person who started in Univen and did my pre-med, you know, if you get called and recognized by your people at home, it's sweet. It's much sweeter. I get invited in conferences internationally, nationally, but this is much more close to my heart. Rutendo will tell you how excited I am when I get to interact and discuss with the people from Univen. I actually sometimes come and drive in and just go and see my old room in F4 and get excited to just that. So given this opportunity, I'm very excited. I am also in private institution. I'm working in Mediclinic Limpopo and in Netcare Puluso Hospital. I also come to Toyando at Dr. Nangambi's practice every first Sunday of the month, and I'm there for those who would want to come and have a consult or have some discussion. I'm available as well. You can call me at 015-296-6530. 015-296-6530. Rutendo, Ndoribu.
All right, Oma, we are excited to have had you. We're excited to have had you in particular times. Excited to have you. All right, that's okay. For everyone else who would like to contact Dr. Muavha, they can contact me in the future if they don't have his contacts. But I see your website is also active, so we have your name. We can find you online. And I'm glad you also come to Dr. Nangambi Center, which is right in our town. So, yeah. All right. Yeah, thank you very much, Dr. Moore.
Ndoribu,
Nda.
Nanda.
Thank you very much, Doctor.